Good evening, everybody. I'm Katie Henderson, Vice President and Chief Medical Officer at Barnes Jewish Hospital. I want to welcome everybody who's here with us in person and to those who are attending virtually. Thank you for joining us for the last Leading Edge Medicine event of this calendar year. Our Leading Edge Medicine series is an exclusive opportunity to hear firsthand about the incredible innovation and discoveries happening right here in St. Louis because of your generosity. Thank you for making a world of difference every single day for our patients and their families. The Foundation is honored to partner with you. This partnership has led to tremendous advances, including the one we're going to talk about tonight, Targeted Goals of Care Initiative. So I debated about doing this, but I'm going to go ahead and go off script, which probably scares my Foundation colleagues a little bit. I just do want to share, this topic is really of personal importance to me. I feel very strongly about hospice and palliative care. My father died a few years ago and had interstitial lung disease. He essentially had pulmonary fibrosis. And toward the end of his life, he was on about 20 liters of oxygen, high flow oxygen. And every time he would stand up, he would desaturate down into the 60%. Normal would be high 90s to 100. When you get that hypoxic, you essentially have chest pain all the time, and you have a lot of air hunger. So we had various oxygen setups for him in the home, and when he would kind of reach the end of his tether with some of his oxygen tubing, he would need to switch to a different oxygen tank. And there was one incident that I didn't know about at the time until my mother shared it with me later, where he went to use the restroom, switched to a different tank, but forgot to turn it on. So he desaturated while he was in the bathroom, and she found him passed out in blue on the floor. She was able to put oxygen back on him, and fortunately he revived at that point, but that scared her so much that she wouldn't leave the house anymore. She wouldn't leave him. So when I went back to visit them at Christmas at that point, it had probably been a couple of months since she had left the house. She was ordering groceries in, and she wouldn't leave him for anything because she was convinced that that was going to happen again and he would pass away and she wouldn't be there. So while I was home, because of friendship with Patrick and others, I know about hospice and palliative care, I was able to get him connected with the hospice program. So they came in, and through the care that he got, he finally had his pain under control. He had his air hunger under control. The help that my mom and my dad got from the hospice folks enabled her to occasionally leave the house and feel comfortable that when she did that, he was going to be well cared for. So it made a world of difference to both of them. And that would not have happened without the support of hospice. So I really do feel a personal connection to this topic. So with that said, I will go back on script because this is a very important program and it has a lot of history, and a lot of donors have helped us get to this point. So I do want to share some of that history. And I'm going to go on the script here so that I don't miss any of that important history. So the first important step actually began when Dr. Patrick White arrived at Barnes Jewish Hospital in 2016, and hospice care in St. Louis would never be the same after that. In 2017, with unprecedented community and donor support, BJC Healthcare opened an 18,000 square foot hospice house called Evelyn's House. It is named in honor of Evelyn Newman, a well-known community leader and philanthropist. Evelyn's generous spirit inspired her family, led by Andy and Peggy Newman, to make a special gift. Together with other donors to the foundation, it has given hospice care a home. It also opened the door to advancing the full spectrum of supportive care to improve the hospice experience for more patients and their families. Dr. White was the first leader at Evelyn's House. In 2019, he was installed as the inaugural Stokes Family Endowed Chair in Palliative Medicine and Supportive Care, a position made possible by the generosity of Aya and Pat Stokes. Taking it a step further, the Stokes gift was matched by John and Ann McDonnell to launch the Supportive Care Institute and the Division of Palliative Medicine. In 2023, continued donor support from the Eric P. and Evelyn E. Newman Foundation created Evelyn's House at Home to support patients with complex symptoms so they can receive care at home, like my father was able to do. This means the extraordinary care provided at Evelyn's House can now take place in your very own home. This breakthrough care is just one in a series of breakthroughs that have come through the Supportive Care Institute. The Newman family also provided pilot funding for a novel research project led by Dr. White and Dr. Nathan Moore. The project focused on developing a screening algorithm using machine learning to identify high-risk patients who could benefit from palliative care engagement. Dr. Moore and Dr. White completed their research in 2021 and implemented their discoveries through a targeted goals of care initiative. Ultimately, the initiative helps physicians identify patients in the hospital who are nearing the end of life but are still able to have conversations about their personal goals of care. The initiative also includes training for physicians on how to provide personalized and compassionate counseling to high-risk patients. In addition, it helps patients identify the benefits of hospice care earlier in their end-of-life journeys. Tonight, we're going to learn more about the tremendous results of this initiative across BJC hospitals. Dr. White, Dr. Moore, and the Supportive Care Institute research team are also exploring novel methods of enhancing support for caregivers and developing innovative approaches to reduce pain, nausea, and other symptoms in patients with serious illness. Overall, their goal is to advance hospice research and revolutionize end-of-life care. And it all started right here thanks to the dedication and drive of Dr. White and Dr. Moore and your committed support. Dr. White is passionate about making life better for patients and their families. He is a national leader in teaching medical professionals and hospital systems to recognize that outstanding hospice care is better for both the recipients and the providers of that care. Dr. White is currently the Chief Medical Officer of BJC Home Care and Hospice, as well as the Chief of the Division of Palliative Medicine at Washington University. He is also the Executive Director of the BJC Supportive Care Institute, which is focused on enhancing support and developing evidence-based guidelines for patients with advanced illnesses and their caregivers. In addition, he has served multiple terms on the American Academy of Hospice and Palliative Medicine's Hospice Medical Director Leadership Council, and also served on the Research Education Strategies Task Force, and many other things, which I will not name tonight, because it goes on and on. His goal is to advance the science of hospice and palliative care through evidence-based research to improve care for patients with advanced illness. Dr. White and Dr. Moore are two leading voices on palliative and hospice care in the country. And tonight, you'll learn how this pioneering targeted goals of care initiative is improving the experience of patients and their families while also benefiting the healthcare system at large. Even more exciting, this groundbreaking work is poised to be replicated at other hospitals across the country. And now I am going to turn things over to my esteemed colleague, Dr. Patrick White.
Thank you so much. It is an honor to be here. Can everybody hear me in the back? Okay, all right, great. So tonight, we're gonna talk about an innovative, impactful program to support patients near the end of life. And we're gonna start out with the patient that really inspired me. Mr. B was a 57-year-old patient. He had lung cancer that had spread to his brain and to his bones. He had pain, he had trouble breathing, he had confusion, weakness, and a very challenging social situation. He had over 90 emergency room visits and hospitalizations at St. Louis hospitals over a 10-month period. And during that time, he'd never gotten a comprehensive assessment, a palliative assessment of what was important to him, what were his goals, and how could we best support him to break this cycle and get him where he wanted to be. Unfortunately, this story is happening at nearly every hospital in the United States right now. There are Mr. B's all across, and there are two sobering statistics that really drive this work for me. The first is that Americans with advanced cancer like Mr. B are twice as likely to be in the intensive care unit around end of lifetime compared to other wealthy developed nations. Twice as likely to be in the ICU. And the second is that up to 1/4 of all Medicare dollars are spent on patients in the last year of life when the benefit is often the least in several studies. And that is heartbreaking for us because we know there's a better way. I bet nearly everyone in this room has either heard of Evelyn's House or had a loved one supported with Evelyn's House at home. I'm going to make some of the amazing people who work there and who volunteer there stand up right now. I see many people who I've seen volunteering, supporting Evelyn's House. Thank you so much. The impact that it has, you need Falcon Vision to read this, but know that over the last 5 years, over 95% of the patients and families that have been to Evelyn's House, those families rate the care of their loved one as excellent. 95% say they would definitely recommend that care to somebody else going through that same journey. Does anyone want to be brave and tell me what the number in the average ICU is of family members that rate the care of their loved one as excellent? So we don't have to do prices right, but somebody throw a number at me. 10%. Frank, I love you. A little higher than that, thank God, so about 60%. But absolutely, huge difference in impact, and it does seem like that sometimes, Frank. And so we want to talk about this initiative. Something that's really unique is that this wasn't dreamed up in the C-suite. This came to us from people in this room and online. You know, when we look back at the transformative moments, you know, I will never forget, we have to start with our board president, Mahendra Gupta, and Ira, who did the initial pro forma. I have not had as much success as they had getting through the hospital budget this year so far, and Katie can attest to that, Dr. Henderson. Next, you know, in 2016, I will never forget having a breakfast when Aya Stokes and Pat told us about their vision for what we could accomplish. You know, there was the moment when John McDonnell pushed back on us and said, look, I want you to dream bigger. Give us the vision that created the Institute. And I'm really excited, and I thought I saw a glimmer of the Chase family here who pushed us. Do we have the Chase? Yes, I'm gonna make you stand up and embarrass you, Jean and Lou, who've pushed us to provide interdisciplinary support to every cancer patient through a gift this year. So just truly transformative coming from you that we have our first embedded clinic. And that leads us to the project that we have where, you know, Dr. Moore is going to talk about how it started. But really what took it to the next level was a dinner in Clayton where Andy Newman and Andy and Peggy have been involved with everything. He stopped us and said, let's do this right now. So instead of the 10+ months it takes normally to get a research grant, we were able to get going in 10 days, thanks to that and our amazing partners at the foundation. So we want to show you that we came from this. We were small but mighty with 7 providers. Where's Aaron Kerwin? Stand, Aaron. Aaron was one of the original, yeah, so 7 providers here. And Vicki Bamer, oh my gosh, okay. A couple of the originals when we were 7 providers before all the energy with Evelyn's House hit. We had less than $100,000 in research funding. Here we are last year. $10 million in NIH funding, over 30 providers. And we are so grateful, you know, the leadership, Dr. Henderson, Joan Magruder, Vicki Frazier, and all of you for building this out and making us one of the premier research programs in the country. So now we're going to get into the exact initiative we did. And I get the pleasure of introducing Dr. Nathan Moore. He is not only an internist, practicing internist at Missouri Baptist, although it's not easy to get in to see him these days, but he also oversees over 600 physicians as the medical director for the BJC ACO. And he has written a book, the Healthcare Handbook, a guide to the US, to the American healthcare system, that is now used in over 100 colleges and medical schools around the nation to explain the complexities of healthcare and work through it. So we're really excited to have him as a partner, as he's a thought leader in this work nationally in population health. Nathan?
Thanks, Patrick. All right, thanks for having me. I get to kind of cover the more boring stuff, and Patrick gets to hit the high notes. But no, it really means a lot to me and Patrick, especially. This is probably the most rewarding thing that I've done in my job in the last 10 years. And we do this, every day. So just earlier today, I was sending out messages on patients that we identified, and it never ceases to amaze me, just the impact. It may seem like a small thing, but the impact, the downstream impact is massive. I was just at an event right before this at WashU, and the lady running the event from one of their departments grabbed me and said, "Hey, I just want to tell you, similar to Katie, my father had an event. He'd been at multiple hospitals. He was struggling. Our whole family was struggling. Somebody got us in touch with Evelyn's House. The last 6 weeks of his life were some of the highest quality times he had in his last 2 years." And she said, so I was like, "Hey, we're going to this. I'm going to this event after this." She just said, "Please let everybody know thank you. You don't know the impact it's having." And not only did it impact him, a few weeks, 6 to 8 weeks later, she realized she was struggling and reached back out to the Evelyn's House team. They put her in touch with a grief counselor who helped her out over the course of several months. They helped. So the impact just blossoms. So it really does have a huge impact. So when Patrick and I, along with Randy Forker at the Institute for Informatics at WashU, we sat down in 2019 and said, let's try to do this better, because we're really struggling here. We looked, and like Patrick mentioned, this is a problem pretty much everywhere across the country. And the barriers that have been identified, why do we have this situation where everybody agrees that advanced care planning is really important and nobody does it? Everywhere. And what the research had shown was, one, it's really hard to identify who are the high-risk patients, who's likely to die. And two, once you identify those patients, how do you engage the healthcare providers, their physicians, and other members of the team to have a high-quality discussion with them? It's hard to do that for a number of reasons. When you go into healthcare, you want to be positive, you want to bring hope, you want to be the bearer of bad news. There's also a diffusion of responsibility, right? I'm just the internist, they're dying of cancer, the oncologist should talk to them. The oncologist says, I'm not their primary care, they're primary care. So there's a number of reasons that once the patients are identified, providers struggle to have high-quality conversations with them. So we wanted to focus on overcoming these two barriers. So Dr. Forker's team at the Department of Informatics built this AI algorithm. It takes over 500 different pieces of information out of our medical record for patients admitted to the hospital within 24 hours. And it predicts their chances of dying in 30 days, which is a little creepy, but quite predictive, quite accurate, very helpful, especially when you compare it to status quo beforehand, which was nothing. We took all the hospital providers over the course of a year and a half, and Devin Odom, who's a hospitalist with palliative care training, developed this phenomenal small group, in-person, 6 doctors at a time with standardized patients, trained, skilled, standardized patients, to teach providers how to actually have these conversations. It's far more effective than any training that I've ever seen. So on a daily basis, for all the patients admitted to any BJC facility, we're running this algorithm every morning. We look for those patients who are high risk that nobody's ever talked to them about it. They might not even be aware that they're high risk. We then alert the attending providers in the hospital and gently nudge them and say, hey, this patient's high risk. Nobody's had the discussion. Would you mind having the discussion, or do you want us to do it for you? And then, and occasionally, well, I'll get into that more, but We started in 2020. We thought this would take us about 2 years to get up and running. We started work beginning of 2020, obviously right before COVID. The health system came to us fall 2020 and said, things are looking grim. We may not have enough ventilators to go around. You guys remember that, or maybe you've put it out of your memory like the rest of us. Patrick got the unenviable job of being the person who would decide who got the ventilator and who wouldn't. And we realized there was no way, A, we wanted to make sure that we were conserving our resources, and B, to have a more accurate way of predicting which patients were going to benefit. But really the goal was to avoid that situation. So the health system said, you know, that project you were working on, instead of in 2 years, could you get it up and running in 2 months? And we got it up and running in 3 weeks. So we rolled it out at Barnes and Mobap in December 2020. We went back and did a real analysis of how things went later. 5 times higher rate of advanced care planning while the patients were in the hospital. And it happened twice as quickly in the hospitalization. 3 times as many patients changed their code status. So you may be aware, when you come to the hospital, somebody's supposed to ask you, if your heart stops or you stop breathing, would you want CPR, would you want a ventilator? The hospitalists and the other providers, but primarily the hospitalists, they're supposed to have an in-depth discussion with every single one of their patients about this. But as you can imagine, that's very difficult if you're taking care of 18 patients, maybe 10 new patients every day. So oftentimes the default is just patients of full code. It turned out when we asked them, about 20% that wasn't right. We had the wrong assumption, and that was in the medical record. The goal of this program was not to switch everybody to a no-code or hospice. It just turned out that there was a huge need there that we weren't addressing. And we're only alerting and asking these questions for the top 2 or 3% of risky patients in our hospitals. The other thing that we've seen is once the providers learn how to do this for the risky patients, they're going back and doing it on their own before we have to bother them. Our goal is kind of to put ourselves out of business here. So then, the system saw the impact it was having and asked us to roll it out. So we rolled it out to 6 additional hospitals across the system over the past couple of years. So it's now running at our 8 largest hospitals. And one thing, we've gone back recently and calculated kind of the long-term impacts, which we're going to share with you today. One thing that we do want to point out, so for the average alert in our medical record, the response rate from physicians is about 15%. And those of you who work in the hospital, I can see nodding your heads, because most of the time they just ignore the alerts, move on. Now, 3 years in, 93% of our providers engage with our alerts that we send to them, and that is maintained over time. And they disagree with the prediction, which benchmark is about 40%, only 7% of the time. So we've been able to, with a combination of the accuracy of the alerts and the provider trainings, maintain this engagement with the providers, which was our second barrier. So this is kind of the money slide. So when it comes to taking care of patients near the end of the life, and then near the end of life in our hospitals, there's this measure, the Vizient Mortality Index. It's the number of patients who die while being actively treated in the hospital divided by the number that would be expected to die. So it's golf scoring. The lower the number, the better you're doing. So we had been around a 0.87 for a number of years, which translates to about 35th percentile nationally. Since we've instituted this program at the end of 2020, we've improved by 29% and gone from about the 35th percentile nationally to almost the 80th percentile. And this, keep in mind, the alerts, we were sending these on the hospital floor patients, not the ICU patients. These were not the sickest of the sick. And you can see in the blue, we've gone from, what was that, 1 in 500 patients has advanced care planning documentation, if I'm calculating right. 1 in 500 of somebody that comes through the door, even though almost 10% die, has documented advanced care planning in the hospitalization, to nearly 10%. And it's no surprise that as that's improved, the care of patients near the end of life has gotten tremendously better. And Patrick and I are up here, but it has taken the the real dedication and input of and effort of a lot of people. This was in nobody's job description. We went to each of these hospitals and asked people to do it in their spare time to fit it in, and we did. So there's a number of people that we literally could not have done this without them. And now that the system has seen the impacts, they're investing in it. Like Patrick mentioned, the number of donors have really invested to get us to this point, and it's been great. The BJC finance team went back and did an analysis, because it's one thing to do the right thing for patients and families. It's another thing to do the right thing and for it to be financially sustainable. What they found was that the reduction in costs just for the patients who ended up in the ICU paid for the program and then some. It doesn't take into account the improvements in quality, the reduction in cost. The patients never make it to the ICU, reduced readmissions. So we are finally in a situation where we can do the right things for patients and families, and the health system financially benefits at the same time, which is very rewarding. I should mention also, we got tremendous support initially from the BJC and WashU Healthcare Innovation Lab. If any of you all participate with that, they were the ones who gave us the initial seed funding to get all this going, so we very much appreciate their help as well. So we've seen a lot of really beneficial downstream impacts as well. Our inpatient hospice has gone up 150% in the past 3 years from a pretty high baseline. Our home hospice has increased substantially, and we're now moving into the other areas that we wanted to initially. We're now in 6 ICUs, which Patrick's going to talk more about. We've also started spreading it to the primary care offices, so we've got almost 300 primary care providers that we're now using these alerts for on the outpatient side through the BJC Medical Group. We're in the process of getting ready to roll this out for home care patients, which is an oftentimes ignored population that's very high risk. We're working with our informatics colleagues to use next generation things like ChatGPT to start bringing in even more information to make our algorithms even better. A number of other health systems, since we published this and presented this, a number of other health systems have reached out and said, can you do it for us too? So we're in the process of doing that. And Patrick will talk more about the enhanced bereavement support for patients who die in the hospital. So I'll stop there, turn it back over to Patrick, and thanks again.
So we are down to our final 3 slides, so have no fear. But we realized that doing this in the hospitals, we're reaching patients too late. People really deserve to have this discussion with their primary care provider or their cardiologist or their oncologist in the outpatient setting. And we've been really thrilled to see that as we've expanded our palliative care, the number of those outpatient visits has increased dramatically. And we're excited about going into groups like oncology with our first ever embedded clinic in congestive heart failure. And so talking about the ICUs now, this was an area that we knew was important because historically the way that this has happened is that the physician, often the family has a discussion with the critical care physician, followed by the palliative care physician, followed by a member of the hospice team. And we said, this is too much to put families through in the ICU. What if we got one embedded provider that turned those 3 talks into one, then that the team could trust because they see them every day? And sure enough, doing that, we saw a huge increase, 80% increase in hospice. We saw a 29% reduction in ICU length of stay. But the part that really hit home the most to me is when we did this in our neuro ICU. I don't get to save lives very often. I'm just going to be honest about that fact. We had a 62% increase in organ donation when families had the chance to have that discussion a little earlier. So huge impact on some of the key metrics. And so this is my favorite slide, okay? And I'll tell you why, because this is where we're going to transform care next. The first part of it is, unless you've been through this process, you often have no idea to expect the changes in breathing and secretion. Sometimes people call it the death rattle or agonal breathing, which if you don't know to expect it, it can be every bit as traumatic as those names say. So what we're really excited about is partnering both with the Barnes Jewish Foundation and the Hospice Foundation of the Ozarks to build videos that caregivers can receive. So even if they're not ready to talk hospice or palliative care, they can just get more information about what to expect delivered to them. Okay, you want to know about the bears. Here we go, all right? Because what better way to close this out? Well, we've known about the bears for a long time. And what's special about the bears is under the armpit of the bear is a chip that can be implanted. And what we do is we tape record the heartbeat of a patient or a message that they want to give to their loved one. And then we stick the chip in. And I can tell you that I've had moms that lost their child 10 years ago that go to bed every night with the bear that reminds them of their lost child. And so I am so honored to say that we realized our adult families, this is just as meaningful to. And that thanks to a combination of the foundation, the Newman Foundation, and Build-A-Bear Foundation, you knew they were going to be in on this. Come on, they're St. Louis too. That we now have 375 bears that are periodically getting distributed to all of our hospitals in this area. And the first batch just went out. So for us, this type of work is so meaningful to help take a little bit of the sting, and that takes us back to the inspiration. So when we finally were able to get Mr. B over to Evelyn's house, get his symptoms controlled and support him the right way, we got him into an extended care facility. And our nurse, our chaplain, our social worker went to him. And I was doing a home visit on him when he grabbed my arm. And he said, and he always called me Dr. Black because his name's Richard Black, okay? And Richard said to me, he said, Dr. Black, he said, I want you to make a promise that while I'm grateful for everything your team has done, where were you 4 months ago? And that really stuck with me. And I said, I promise. And he said, the other promise is that you use my name. You remember my story after I'm gone. And from October till he passed in December, you know, it was just really powerful to me that I wanted to get a chance to honor that wish. So I want to close by thanking all of you tonight that have made that a reality. And now the man, oh, thank you. Thank you so much. And now the man that started it all is going to be questioning us. Is that, oh, no.
Thank you guys so much. That was a wonderfully engaging presentation. At this time, we are going to take some questions for our physicians. I'm going to hand this down. I'm going to come around.
I, among many others, have been through this. And there's always that element of guilt for the family. So how do you deal with that? And then I have a challenge to you all. Make this a right to die state.
Well, I'll give Nathan the hard part of that, and I'll start with the first part of that, okay? One of my favorite things, and Peggy, how many hours have you had at Evelyn's house? It's got to be like, yeah. So just somebody who's been on all ends of this and supporting this work. For us, you know, having these discussions earlier, that's what takes away the guilt. When you make your wishes known and your family can look back and see, this is what Dad wanted. He was very clear with us. He was not to be on those tubes in the ICU. That's what makes all the impact, takes that guilt away, and they know they did the right thing. I have told my children that, my wife knows I will haunt her if she leaves me in that scenario. And so I think just having that discussion earlier, the right to life, should I put you on the spot or do you want?
I got nothing to add.
Okay. I think that in our community, that is a huge topic. And I think even among us, providers are split right down the middle. There's so many religious and other, factors that I think are considered that it's just tough to give an answer to. But I can tell you what we all agree on is that families should know what the heck is happening to their loved ones. Patients should have the chance to participate in the discussion. And we can do such a better job taking away people's symptoms at end of life to make this journey so much easier on everyone.
Yeah, just to echo what Patrick said, when we put up there that these discussions were happening twice as early in the hospitalization, that doesn't include all the ones that weren't happening at all. So our goal really is, like Patrick mentioned, when the patient comes in the hospital, before they're incapacitated, one piece of feedback that we got from the providers that really helped drive our engagement, we went back to the hospitalists after a few months and said, why the heck are you guys doing this so much? Why are you listening? And the nighttime hospitalists, you guys may or may not be aware of this, but normally there's a whole team of hospitalists during the day, but at night there might be one or two that are covering 200 or 300 patients. And if they don't see most of the patients, but if somebody's in distress, they get called. So they said, status quo is at 3 in the morning, I get called for a decompensating patient who I've never met. I'm going to the room, trying to assess them, trying to figure out what sort of care they want, if they want CPR, if they want intubation. There's no patient, there's no family around. It's the worst possible way to provide care. They said, now, the majority of the time that I get called, I look, somebody's already had the discussion, it's already documented, the family members are well aware. Not only is the patient treated better, and the family is less guilty, the providers are also much happier. So really everything that we're doing, especially now moving into the outpatient space, is like Patrick said, if you put the patient in charge and let them make their wishes known, it really removes most of the guilt. And that's really where our focus is.
Great presentation on a hugely important topic. One of the questions I have is, you referred briefly to AI in the presentation. Can you explain how AI is used in the last maybe 2 or 3 years, but more importantly, where you see it in this whole continuum in the future?
Yeah, so the way we use it in our algorithm, and I'm not the technical person, but it takes over 500 different types of information out of the medical record, runs it through actually 4 algorithms that are combined to generate that risk score of the patient's risk of dying in the next 30 days for hospital patients. We don't actually know how it comes to the predictions that it does. That's one of the things that we're working on now. And we didn't share it here, but the accuracy is about 80 to 90%. Whereas before, statistics show if you just ask the physicians to predict, it's closer to 30 or 40%. It also gives people the permission to have these discussions with patients. We're not entirely sure what it's going to look like the next couple of years. As I mentioned, the next step that we're working on now is how to bring in things like notes and imaging results that are unstructured, just text, extract the information out of there and bring it into the algorithm to improve the performance. What we don't want, what kind of keeps me up at night, especially when we started this, was waking up and opening the Post-Dispatch and it said, BJC using computers to tell patients when to die. So what we actually do that makes our process less efficient, but we think much more effective, is we have multiple steps along the process where a human has to review the patient and the alert before it goes out to the team. So we think that the combination of artificial intelligence and human intelligence really is what makes this program more effective. When we go to meetings and conferences, people think AI is going to be a solution to everything. I think it's really early to know what it's going to look like. But it's certainly an exciting time. The other question, really I don't think people are aware that already AI is used for a lot of things, and patients aren't aware. So you can expect that if you're interacting with the healthcare system now, you're already receiving some level of AI-driven care just without knowing it. So what we're trying to do is put the patient and provider kind of at the heart, not let the AI drive the care, but using it as a tool to improve the care that's being directed by a healthcare professional. Anything you wanted to add?
No, that's
Did that answer your question?
the great Maryland man, who led an effort to get a documentary that will go nationally in March. Thank you, Maryland man.
So, my question is, what are you doing, Dr. White, to make this knowledge about palliative and hospice care and the need for advanced planning available to the general public?
Yeah. So I can say to that, wow, that was louder than I thought. I can say to that, one of the things we're doing now is picking other partners in different settings. So we wanted to support rural families. So with the Hospice Foundation of the Ozarks, we're working in a partnership to make a lot of educational videos. There's another documentary that's in the works to try and help the public understand. There's going to be a book written about our program here at what we're doing at BJC. A New York Times winning best-selling author is choosing 5 programs to talk about hope. And she loved this project that Dr. Moore and I are working on, and Randy Forker. So you know, getting it out to the public, if you have words of wisdom, let us know, because that has vexed us for many, many years. You know, what is the best way to connect with people? But I'd say a combination of using the media. Yep.
I just wanted to add one somewhat related topic, which is when it comes to end of life, especially palliative and hospice, there's a assumption or a feeling among healthcare providers that Black and Hispanic patients aren't interested. Would you say that's? Yeah. And there's also, as well known, kind of related to your other question, that a lot of the AI algorithms that are out now are biased. And that's been well published. So one of the things that we did when we started this was we made sure that the algorithm was equally accurate in minority and white populations as well, male, female, and various other things. But we also went back and looked at how the program impacted patients of different types. And not only did Black patients benefit just as much as white patients, it was actually greater. So it turns out that it wasn't that they didn't want to talk about it, it's just the providers didn't think they wanted to talk about it, so never asked them. And once we, again, gave them the permission to ask the patients about it, they had the same feelings that any other patients did. It's just that they weren't being asked about it initially. So that's one of the things that we've been really happy about, is that we think we're having a big impact in those populations also.
Yeah, so Patrick, I just want to congratulate you. I think one of the things that I've seen in the 27 years I've been here is your recruitment and the establishment of this program and the impact that it has on patient care. Because we need to think about patient care, whether it's cancer, heart disease, transplantation, et cetera, not just from diagnosis and eligibility to those patients that have end-of-life issues. And you have done a spectacular job, in my view. Your colleagues should all be congratulated because, like cancer care, it's a passion. You know, it's way above expertise and medical expertise, and so you should be congratulated for that. But I do have a question. And, you know, on your slide, you started out pathetically at 0.2%. So 1 in 500 patients had a discussion about end of life. You're now 10%, a phenomenal increase. But how do we get to the 50 or 80%? As a dinosaur here, I was never trained about end-of-life care. And all of us recognize the importance of expenditure, emotional expenditure of families who have to watch loved ones who are incommunicative in a end-of-life situation in an ICU, intubated, et cetera, et cetera. And so how do we make this kind of a program on steroids for our providers?
So,
For our providers.
So I think that is such a great comment, and I just want to start off by saying this was completely a team effort, and that there's so many of you who built this up. I've played just a small role compared to what's been done. But regarding the second question, there have been a couple of communities that have just said, hey, at every visit when you go in for your annual checkup, we're just going to learn about your wishes. And in those communities like La Crosse, Wisconsin, you can get as high as 96% of patients who die with their wishes known and documented. And they actually won, talk about ending on a prestigious award, Forbes magazine's best place to die in America. And we could bring that to St. Louis, people. That is within our reach. Thanks so much, Dr. Eberle.
We are going to take, go ahead, please, go ahead.
I was just going to your question, that's why we're moving upstream. We want to do this with the providers and patients in the office before they end up in the hospital. I'm trying to imagine that billboard crossing the Mississippi River, best place to die.
We are going to take 2 more questions. Please go.
Is this on? So anyway, hi. Having come from the trenches of having done this work, I was wondering about reimbursements and how that's gotten better, because a lot of this all sounds great, but nothing's ever free in medicine. So I know that they're reimbursing for these conversations, but I wondered, like hospice has programs, but palliative care, how that's coming along so that it is offered for a longer period of time. And having worked at Barnes, realizing a number of the patients don't have insurance. So, just.
Yeah, I'll say one thing from my perspective, which is as the U.S. healthcare system transitions to a value-based care system, hospitals and health systems now make money by reducing unnecessary utilization. And one of the most effective ways to do that is near the end of life. So we've saved, on the BJC ACO side, we've saved almost $85 million from Medicare the past 5 years. And a lot of that is because of this focus. So now, again, it pays, in this particular circumstance, it pays to do the right thing. So some of it is not from revenue, it's from savings.
Now, the sad other point of that, so that is if you're in one of the value-based arrangements, but you're exactly right. Normally with palliative care, even Evelyn's house, we depend on the community to keep our doors open. So that in palliative care nationally, about 50% of the cost have to be borne by the hospital. I am so grateful to work in a healthcare system where we prioritize doing the right thing, and we've been able to build this team, and Evelyn's house is a priority, and all of you have made that happen too. But unfortunately, the reimbursement is much higher for surgeries and ICU care than it is for those palliative home visits, even though they net save money to society as a whole and do the right thing to patients and families. Good comment. I'll just say, I think that's why having these discussions, why Marilyn's work, like normalizing this discussion and bringing it to people and saying it's okay to have that talk. You're not going to make it happen. All you're going to do is help your family to be better prepared and know how your wishes are. The title is Going Your Way. How important is that? So you're exactly right, and I think we just got to keep normalizing it, but that is not part of our culture. And we've got some of the more famous doctors in the history of our healthcare system, and I will say that they will tell you that in their training, acceptance of death wasn't a part of the training in the medical establishment for a lot of years. And it's hard, for providers to take that. So great comment.
We have so much excitement tonight, so we are going to take 2 more questions, but I promise there'll be time after as well. Dr. Kodner.
Thank you. So history was never my forte. Spent a lot of time in the sciences and growing orchids. But I think it's really very important for us to recognize our history and how this all started. And we have to seriously include Washington University, because it started with one of our medical students who took an elective in medical ethics. And he chose a topic of futility. And he surveyed the hospital, and he came back to me. I was supposedly directing this elective. And he said, after surveying the intensive care units in the nursing service, in some of the medical service, what this place needs is a palliative care program. I, of course, had no idea what he was talking about. He had surveyed the intensive care units and found that of the 9 units, a third of the patients didn't want to be there. They weren't benefiting from being there. And the hospital was losing a ton of money because their beds were occupied with people who were no longer getting Medicare reimbursement. So we took him as a lead. We talked to the nurses. We talked to some of the physicians. Most of my colleagues and physicians weren't interested. And for the sake of history, what really turned the tide was this man. We went to the business school. He had faculty and students who were interested in looking at the economics of palliative care. We had 5 MBA students for 5 semesters. They came forth with a prospectus that showed if the hospital would start implementing a palliative care program, they would save $1 million that first year. And if we did it BJC-wide, this was now 20 years ago, they would save $10 million. My only point is history is important. And Dean Greenbaum sitting in front of me, were it not for his impetus and his students, none of us would be here tonight. So I have to personally thank him and you guys for doing a phenomenal job.
Okay, this is our last question, but please, if anyone has any remaining questions, both doctors will be here after the program and we'll be happy to answer.
Thank you. And thank you again for your presentation and a segue to Dr. Kodner. Is there any initiative that's moving into medical schools around the country with this program? And is it part of their curriculum? It's the next generation to carry the mantle. Can you talk a little bit about that?
Absolutely. I'm proud to say it is now part of the standard medical training. There's a couple different ways. One is teaching the communication skills and how to have this discussion with someone at end of life, and that's a standard part of the curriculum. They even now have more specialized courses where you can go to Evelyn's house, you go on the pediatric palliative care service, you go to the VA, and you come with us on our palliative care service. So there are different courses now for people who have an interest, but I'm proud to say now everybody is expected to have at least some competency. And how do you have this discussion with your loved one? Nathan, anything? Okay. Thank you guys. I don't want to steal your thunder.
Well, thank you all so much for coming. At this time, we are going to welcome Mahendra Gupta, our board chair, to the stage to close us out.
What a great presentation. It's information that in one way or another touches each and every one of us. As you heard this couple of stories, I can share mine. My father and my mother both passed away without us knowing what they wanted towards the end of their life. They went into the hospital and never came back, and we did not know that. It is something that is so important. And in this room, everybody sitting here is educated person. I invite you to ask yourself, have you done it? Because if you have not done it, you should. We never know what tomorrow is going to bring. And if you don't do it just for yourself, do it for everyone you are going to leave behind. Give them the power to give you the best end of days of their life. Dr. White and Dr. Moore, one of the things that, as you talked about, this is something that we cannot really leave in the hands of last 30 days of the caregiver. This is something we need to find a way to make it a part of a routine. Today, we have learned over the years to do the financial planning. If you have even a little bit of money, you go to Jones, you go to a banker, and they are going to tell you, okay, this is money, this is your life expectancy, if the money is going to last or not, here's how you need to make your budget and plan. We need to find a way to make this as a habit, something that we do. And in order to do that, there was a great question that was asked in terms of the reimbursement. We need to find an economic equation along with the humanity equation. How it is going to, if 50% of the medical cost is in the last year, what you're talking about can make a huge dent in that. And if we start doing it early on, imagine how much it can change, because it can unlock the capacity. Every doctor and healthcare provider knows that very well. Today, we do not have enough capacity to serve the need of the people. And we will never have that capacity. It takes more than 10 years to make a doctor. Our population is growing at a faster rate than we are developing doctors. So we need to find a way to unlock the capacity and not really get it consumed by something that could be controlled very differently. I am looking at trying to find my remarks. As Katie said, that I need to stick to the script. I was already off the script. So I am Mahendra Gupta. I'm board chair of the foundation. Just going back to the script. And we have come so far in the hospice care because of the leadership of Dr. Moore, Dr. White, and their colleagues in what they have done. And it's incredible the impact it has made on our community and the potential to make the impact nationwide. But one thing is there, whether we are in St. Louis, whether we are in the United States, but if we are born, someday we are going to die. This is a global issue. This is not a local issue. It's an issue that is connected with the humanity. If you have not been to Evelyn House, sometime take a time. It's a beautiful location, and it will fill your heart with peace, with comfort that in our community there is a place to take your loved one. But also you are going to learn about that you don't have to be at Evelyn House. Evelyn House will come to you in many different ways. Palliative care is going to come to you. Be ready to take those best use, but learn about it. Thank you for the great questions that you asked. But more importantly, thank you for your philanthropy. As Dr. White and Dr. Moore said, that they cannot do this without the constant support. The reimbursement of the healthcare will not continue the place like Evelyn House for even a month. So it is important that we as a community continue to support the initiatives of Dr. Moore, Dr. White, and others like them, till the time comes that we discover a self-sustaining solution. Thank you very much. The bar is open, the food is around, and the doctors are here to answer more of your questions. Enjoy the evening.